Electrolyte disorders. Symptoms are usually more severe with acute changes in electrolyte levels. Occasionally, chronic disturbances may produce signs and symptoms opposite from those in the acute state. In general, central nervous system dysfunction occurs with abnormalities of sodium, peripheral nervous system dysfunction with abnormal potassium levels, and combinations of both with abnormalities in calcium, magnesium, and phosphate. Management is directed at treatment of the primary disorder and correction of the electrolyte abnormality. Neurologic findings usually disappear with appropriate therapy. Sodium. Sodium is the main determinant of serum osmolality and extracellular fluid volume. Therefore, neurologic symptoms are dependent on the time lag necessary for the brain to compensate for rapid changes in serum sodium concentration and thus osmolality. Hyponatremia. Acute decreases of sodium levels to 130 milliequivalents per liter may produce symptoms. Chronic changes to 115 milliequivalents per liter may be asymptomatic. EEG abnormalities are common but nonspecific, with slowing that correlates with decreased sodium levels. Acute hyponatremia, less than 115 milliequivalents per liter, with seizures carries a high mortality rate and necessitates rapid, that is over a 6-hour period, correction to 120 to 125 milliequivalents per liter. Rapid correction to levels greater than 120 to 125 milliequivalents per liter may result in central pontine myelinolysis, CPM, a disorder primarily affecting alcoholics, but also occurring in children and adults with liver disease. Severe electrolyte imbalances, malnutrition, anorexia, burns, cancer, Addison's disease, and sepsis. There is symmetric focal myelin destruction predominantly involving the basal central pons. Asymptomatic chronic hyponatremia usually requires no immediate intervention and is managed by correction of the underlying condition. Hypernatremia. Neurologic symptoms develop when the serum sodium level rises above 160 milliequivalents per liter, or the serum osmolality is greater than 350 osmoles per kilogram. Level of consciousness correlates well with the degree of hyperosmolality. Sudden increases in serum osmolality may produce decreased brain cell volume with mechanical traction on the cerebral vessels, causing subcortical, subdural, or subarachnoid hemorrhage. CSF protein levels may be high without pleocytosis, and the EEGs normal or mildly slowed. Hypernatremia resulting from diabetes insipidus may occur with tumors involving the hypothalamus or pineal region, as well as with basilar meningitis, encephalitis, ruptured aneurysms, sarcoidosis, trauma, or surgery. Treatment with isotonic solutions should be given to reduce the serum sodium levels by no more than 1 milliequivalent per liter every 2 hours during the first 2 days of treatment. Rapid infusion of hypotonic solutions may cause cerebral edema and seizures. Potassium. Almost 60% of total body potassium is located within muscle. Therefore, predominantly muscular symptoms occur with altered potassium levels. Hypokalemia most commonly occurs with diuretic use, but also occurs with GI losses, certain antibiotics, mineralocorticoid excess, and rarely thyroid toxicosis. Muscle weakness usually develops with serum levels of 2.5 to 3.0 milliequivalents per liter, and structural muscle damage occurring at levels below 2.0 milliequivalents per liter. Hypokalemia and hypocalcemia frequently coexist, with cancellation of neuromuscular manifestations. Treatment of one condition in isolation may produce symptoms of the other. ECG and cardiac abnormalities are common and may require ICU monitoring and treatment. Treatment involves increasing dietary potassium, supplements of potassium chloride, and the use of potassium-sparing diuretics. Potassium infusions are occasionally necessary. Hyperkalemia is relatively uncommon, but may occur in familial hyperkalemic periodic paralysis. Quadriparesis may develop with levels greater than 6.8 milliequivalents per liter and levels greater than 7.0 milliequivalents per liter are life-threatening and require intensive care monitoring and immediate therapy, which may include administration of glucose and insulin, cation exchange resins, or calcium gluconate. Calcium. Plasma calcium is a stabilizer of excitable membranes in the central and peripheral nervous systems and in muscle. Calcium concentrations are closely controlled through the combined effects of parathyroid hormone, calciferol, and calcitonin on intestine, kidney, and bone. Hypocalcemia is relatively rare except in neonates, in patients with renal failure, and after thyroid or parathyroid surgery. The tetany syndrome originates in the peripheral nerve axon and initially becomes evident with distal and perioral tingling. Distal tonic spasms may progress to laryngeal stridor and opisthotonus if severe. The EEG is diffusely slow with an exaggerated response to photic stimulation. ECG abnormalities are also common. Treatment of mild cases is accomplished with oral calcium supplements. Tetany or seizures may require 10% IV solutions of calcium gluconate or calcium chloride. Underlying disorders should be corrected if possible. Hypocalcemia often coexists with hypomagnesemia. In such cases, total serum calcium levels may be normal, but ionized calcium levels may be low. Hypercalcemia. Malignant neoplasms are the most common cause of increased serum calcium levels. Mental status alterations occur with total serum levels greater than 14 milligrams per deciliter. Myopathy or carpal tunnel syndrome may occur in association with hyperparathyroidism. Treatment of symptomatic patients consists of saline hydration and furosemide. Occasionally, mithromycin is required. Magnesium. 98% of magnesium is intracellular. It is necessary for the activation of various enzymes. Extracellular magnesium affects central and peripheral synaptic transmission. Changes in serum levels may not reflect total body stores. Hypomagnesemia occurs most commonly as a result of excess renal loss, but may also be the result of decreased intake or absorption. Neurologic symptoms usually develop at levels below 0.8 milliequivalents per liter. The presence of seizures requires treatment with parenteral magnesium sulfate. Oral magnesium supplements may suffice in less severe cases. Calcium gluconate should be available when giving IV magnesium sulfate, as transient hypermagnesemia may cause respiratory muscle paralysis. Hypermagnesemia an uncommon disorder, usually occurs with increased intake and renal failure. Deep tendon reflexes may be lost at levels 5 to 6 milliequivalents per liter, and CNS depression occurs at levels above 8 to 10 milliequivalents per liter. Muscular paralysis is due to neuromuscular blockade. Treatment of paralysis may be accomplished by small amounts of parenteral calcium gluconate and hydration. Otherwise, discontinuation of magnesium-containing preparations is indicated. If renal function is severely impaired, dialysis may be necessary. Phosphate. Hypophosphatemia is often complicated by multiple abnormalities of electrolytes, nutrition, and acid-base balance. The syndrome commonly occurs in malnutrition and chronic alcoholism, especially after the infusion of glucose or hyperalimentation solutions. Acute hypophosphatemia may not reflect decreased total body stores and may produce neurologic symptoms if severe. Chronic hypophosphatemia is usually moderate and may not be symptomatic unless acute stresses, alcohol withdrawal, burns, binding of phosphate in the gut, cause sudden decreases below moderate levels. And those are electrolyte disorders. Have a great day.